Hello, everyone. I think we'll go ahead and get started. I'm sure many participants will be joining, but we'd like to start on time. Welcome to the webinar, Antimicrobial Resistance in Low Resource Settings and Displaced Population. This is the first joint webinar between the International Society of Antimicrobial Chemotherapy and the European Society of Clinical Microbiology and Infectious Diseases. My name is Souha Kanj, and I am Professor of Medicine and Infectious Diseases at the American University of Beirut Medical Center. I'm currently President-elect of ISAC. I'm very pleased and honored to be co-chairing this webinar with Professor Robert Skov from the University of Copenhagen. He's a medical doctor and specialized in microbiology. Previously, he was the scientific lead of the International Center for Antimicrobial Resistance Solution, known as ICARS. Professor Skov is currently the president of the European Society of Clinical Microbiology and Infectious Diseases. Both Robert and I have long-standing interests and work in the field of antimicrobial resistance. In this webinar, we will address one of the most pressing public health challenges of our times. As you all know, displacement and conflict environments often exacerbate the spread of infections, and the global rise of resistance adds complexity to managing these health crises. We are honored today to have two distinguished experts with us to share their insights on this critical issue. And without any further delays, I'd like to pass the microphone now to Professor Skov to introduce the first speaker. Before I pass the microphone, I'd like to tell you that we're going to have questions and answers sessions. You have the link for Q&As. So whenever you have a question and throughout the webinar, please post your questions, and we will be very happy to address all of them during this webinar. Robert, the microphone is yours.
Thank you very much, Souha. And first of all, I really would like to thank the International Society of Antimicrobial Chemotherapy for hosting this great event. And I really look forward to this collaboration that we are now starting with these webinars here from ISAC and ESCMID together. It's also a really great pleasure for me to introduce you to the first speaker, Dr. Guido Granata from Italy. Guido Granata is an MD and a PhD and specialist in infectious diseases and work at the research department for infectious diseases at the National Institute Larazzo Spallanzani, or something like that, you can say, Guido. So Guido has been co-authoring a couple of papers on the impact of armed conflict on the development of global spread of antimicrobial resistance. So it's really a very good chance now, Guido, to give your talk about this, about the human conflicts as a source of dissemination of AMR. I really look forward to your presentation. Thank you. And the word is yours.
Thank you, dear Robert, Professor Skov. Thank you, Professor Kanj, for this invitation. I'm really glad. I'm honored to be here. I want to say thank you to ISAC and to ESCMID for this webinar. And let me share a few slides, a few data I want to present today. Armed conflicts have been implicated into antimicrobial resistance and development, and cases of antimicrobial resistance bacteria have been described since, I would say, World War II, and cases have been increasingly reported in more recent conflicts, but currently we have scant data on the burden of antibiotic resistance during geopolitical conflicts, and also we have scant data on the exact causes of antibiotic resistance during wars. To notice, even in the last 20 years, we faced, sadly, unfortunately, we faced the outbreaks of a number of several major conflicts all over the world. This is only a short list, but we have also conflicts in Latin America and in Africa and in Asia as well. But we only have available data on a few of these conflicts. And today I will try to briefly summarize most of the evidence that we dispose at the moment. Recently, a systematic review has been performed and published on this issue, on the prevalence and on the causes of antibiotic resistance during the wars. And 34 studies were identified and included in the study. And overall, the quality of the studies was not excellent, was high in 47% of the studies and only medium in the half of the studies, the included studies. And the factors limiting the quality were mainly the impossibility to distinguish between patients or soldiers' injuries inside the conflict zone or outside the conflict zone, inadequate sample size sometimes. Also, there was quite an heterogeneity of the collected studies, a variation in the definition of what a bacterial infection is and what antimicrobial resistance is and what pan-resistant bacteria are indeed. And also, it was not easy for some studies to distinguish between colonization or actual infections in the included patients. But of course, one common limitation that we can highlight in the study we included is the difficulties, the challenge of conducting research in a combat zone. I'd like to start with a study from the Bosnian conflicts. So in the early of our century, at the start of our century, because this is one of the study assessing the rate of Acinetobacter baumannii infection. It was a prospective surveillance study assessing two different periods of time. So we have a peacetime and a wartime. And what the study highlighted and was the message that we received is that infection boomed up during the wartime, with a rate that was 3 times higher than during peacetime. We also have limited evidence coming from the Lebanon conflict, the previous Lebanon conflict, that one that ended around 2017. And we have a study including 772 patients and depicting high rate of multi-drug resistance bacteria, including Enterobacterales and also Staphylococcus aureus, methicillin-resistant Staphylococcus aureus. Then we come to the Libya conflict, and I think during the conflict in Libya, we had more consistent data, and we have two main studies that included altogether an overall 1,200 patients, and the study described again a high rate of multi-drug resistance bacteria. And the bacteria were mostly Acinetobacter baumannii, again, but also Staphylococcus aureus and Escherichia coli and Klebsiella pneumoniae. And for the first time during a war zone was described the presence of a gram-negative bacteria producing New Delhi metallolactamases and also OXA48 carbapenemases that are dreadful enzymes causing pan-drug resistance nowadays. This is the study highlighting the high rate of multi-drug resistant bacteria in patients and soldiers coming from the Libya conflict. And again, it identified New Delhi metallolactamases and OXA48 carbapenemases. Then we had several data coming from the Iraqi conflicts and also the Afghanistan conflicts. From these two different conflicts, these wars, we have more than 22 studies, and the studies alarmingly reported an overall multi-drug resistance rate up to 80%. Again, Acinetobacter baumannii was one of the main key player of multi-drug resistance during the war, but we also have Klebsiella pneumoniae. Again, the presence of carbapenemase genes, including OXA41 and OXA23 and other oxacarbapenemases, was described. And for the first time, the study confirmed the key role of nosocomial transmission in military hospitals as the major cause of transmission of antimicrobial resistance during the conflicts. And also, we started to obtain, to have evidence of antibiotic treatment and broad-spectrum antibiotic treatment as a risk factor for the development of colonization by gram-negative multi-drug resistant bacteria. To give a few data, a few numbers to give an idea of the percentage we're speaking about, this study performed on a military ship during the Iraqi conflict included 211 war-wounded patients, and of them, 56 met criteria for infection. The majority of the infection accounted for wound infections, but we also had bloodstream infection. Acinetobacter baumannii in this study exceeded 80% resistance to all the drugs, the antibiotic compounds available at the time. Also, other studies coming from the Iraqi and the Afghanistan conflicts describe a difference in the percentage of multi-drug bacteria colonization among combat wounded patients and non-combat soldiers. The study included 2,700 wounded soldiers. Of these soldiers, 1/3 received a diagnosis of infection, and 27% of these patients were identified to have multi-drug resistant gram-negative infections. So it's a strikingly 9% of all the patients included in the study. The incident density reported was 0.6 for 100 person days. And again, the study confirmed that broad-spectrum antibiotics and non-proper antibiotic administration is a risk factor for the development of multi-drug resistance during the war in a military hospital. Then we come to the sadly ongoing Ukraine war. And Ukraine war provided the opportunity to study antimicrobial resistance in a more extended way. We have at least 8 major studies reporting on this issue. Altogether, they included more than 1,000 patients evacuated from Ukraine. And again, it is documented an alarming spread of multi-drug resistant gram-negative bacteria producing New Delhi metallolactamases and OXA48 carbapenemases. The rates of resistance are alarming, and even for the most recent available antibiotics, we have resistance rates up to 80%. 80% for ceftazidime-avibactam, up to 95% for ceftolozane-tazobactam, more than 80% for meropenem-vaborbactam or imipenem-relebactam. Also, cefiderocol was reported an alarmingly high rate of resistance, and we have 6% of the included isolates overall of Klebsiella pneumoniae that were pan-drug resistant. Again, the transmission seems to be nosocomial, and probably in the military hospital setting, and the study suggests that antimicrobial resistant transmission events are before the transfer of these patients to other hospitals in Europe. the studies documented the dominance of New Delhi metallolactamase and OXA48 carbamazepine, resistance to the novel antibiotic compound, such as ceftazidimab-vibactam and ceftolozane-tazobactam. And of note, there is a retrospective survey conducted in Germany on over 70,000 isolates that described the increase of gram-negative producers of NDM and OXA48, in particular Klebsiella pneumoniae. This study documented and reported on the spread of these bacteria, adding to the baseline incidence in Germany before the Ukraine war occurred. So this is one of the first evidence available on the spread, on the global spread of multi-drug resistance bacteria from a war zone to other countries and then globally. What can we do? How can we face the spread of antibiotic resistance due to the conflict in Ukraine, but also due to other conflicts occurring right now? Well, of course, conflicts and armed conflicts led to displacement of people, and thousands of refugees from war countries to other medical facilities located in other countries. And recently, the European Center for Disease Control recommended preemptive isolation and screening for this patient. And there are also ethical issues undergoing. But I want to highlight that when reviewing the main guidelines for the treatment for abdominal, skin, and soft tissue infection, war wounds are not mentioned, and there are no specific recommendations. Also, I want to show you some data on the causes of antibiotic resistance during armed conflicts. Of course, we can postulate several hypotheses, quite sound hypotheses, but hypotheses as well. Yes, during wartime operation, there is indeed a pressure to quickly treat wounded soldiers, and this pressure can lead to indiscriminate use of antibiotics. We have to consider that combat-related injuries often result in devitalized tissue, contaminated tissue, and this can favor the development of resistance, and also infection control is challenging. And practices like cohorting or isolation or even proper hand washing are difficult to implement. But in more general terms, the disruption of the healthcare system and people gathering in shelters for protection can cause the spread of multi-drug resistant pathogens from soldiers to civilians. But these are hypotheses, and I think they should be confirmed through more and future studies. The available study on the causes of the origin of multi-drug resistance during conflicts are actually not so many. We have 3 studies on the origin of multi-drug resistant outbreaks in a military facility, and the evidence coming from the study show us that the introduction of the organism from environmental contamination in the time of the first hit on the battleground is unlikely. The most recent studies, surveillance studies employing molecular and genetic characterization, suggest nosocomial spread, nosocomial transmission within the military healthcare facilities. Also, as I mentioned before, we have evidence that not appropriate use of antibiotics can favor and is a risk, can be considered as a risk factor for the development of resistance. The good news is that the data we have show an efficacy of active surveillance and infection control, proper infection control, in controlling this spread of antibiotic resistance. A 3 years surveillance study performed during the Iraqi conflicts showed that active surveillance, antimicrobial stewardship, and also proper infection control reduced the rate of Acinetobacter infection in a military hospital. So to conclude, we can say that the studies on antibiotic resistance in Ukraine, but also in previous conflicts, revealed high rate of resistance, even to the most recent compounds. The origin of these outbreaks are mainly nosocomial, so the studies confirm the key role of nosocomial transmission in field hospital. And given that the studies dating back prior conflicts consistently documented the isolation of strain resistant to all the antibiotic available at that time, and also predicted the spread of this bacteria, the global spread of this bacteria, the high rate of New Delhi beta-lactamyces and other carbapenemases during the most recent conflict is alarming. Is alarming, and of course, this threat is not limited to the Ukraine conflict, but also to Gaza or to Palestine, and also to the Lebanon conflict that is currently taking place. It is difficult to propose initiative to face this antimicrobial spread. The easy answer, of course, should be stop making war, but probably educational initiative may help, and educational initiative targeting healthcare providers in military hospital. Educational initiative also should promote the proper use of antibiotics and promote awareness on the risk associated with antibiotic resistance. It is important to keep in mind, to take in mind the message that multi-drug resistant gram-negative infections usually are hospital acquired or military hospital acquired, but not battlefield acquired. And of course, it is imperative to strengthen the infection control measures. And also we have to consider, in my opinion, that not every armed conflicts and not every wars are the same. We have a variety of setting and geopolitics and geographic differences and climate and difference, but in general terms, emergency medical care is provided by different organizations during a conflict, including redeploy local workforce, World Health Organization, United Nations, also allied nations, also NGO. So active collaboration seems to be needed and essential. And I think the steps should be aimed to mitigate this risk and safeguard the efficacy of antibiotics for our future and for future generations. Thank you.
Thank you very much. Guido, this was a very, very interesting talk here. So we will take just a couple of questions here, just to let everyone know that we are, you can put out your questions in the Q&A box, and we will try to answer as many questions as possible live, but there will also be the possibility for writing that we can answer the questions directly. So the first question here is, what principles will govern the ethics of AMR research in a conflict? Oh, now it's moving when you're writing. Okay. And when resources are limited for regular care, and also further, what measures can be taken to minimize the discrimination that arises from AMR-related studies in refugees and displaced people?
Well, Robert, when looking at the available data, I noticed that most of the available studies are observational studies and survey and also surveillance studies, of course. I think we are still in a phase in which it is crucial to obtain data. and to describe what we have found, because there are many gray zones, as I try to highlight in this regarding the antimicrobial resistance during conflicts. It is quite clear that it's a problem not limited in the war zones, but can quickly and fast disseminate and spread all over the world. And I think this is the key message and a lesson that we should learn from previous conflicts. And it is difficult to me to answer about the ethics of conducting this kind of research, but I can feel the importance to understand what's going on and trying to stop the spread of antibiotic resistance, not only, of course, in the conflict zones, for the benefit of patients and refugees and soldiers, but also for the benefit of all of us all around the world. Because as I showed you, this bacteria disseminate, and there is a documented transmission and spread from one country to another. So it becomes a global problem.
Yeah, sorry. There seems to be some echo at the moment, but I think it has been solved. So just one comment I can see here from Revati Guntoro, who says that the data that you showed, that with these very broad spectrum agents being so highly resistant, that is really very disturbing. So that was just a comment I saw here in the chat. I also saw one, what is your viewpoint about the diagnostics in such a situations? Obviously that is challenging, but do you have any viewpoints on that?
Yes, I do have. I want to say, for me, it is crucial. I was trying to say during my conclusion that not every conflict is the same. It also regards the health and health structure of the countries that are facing the war or the armed conflicts. For example, in the Ukraine war, during the Ukraine war, it seems that at least a few microbiology laboratories was able to keep going, working and processing samples, and it was luckily it provided data. And as a result, we have at least some study reporting on the incidence and on the feature of this antimicrobial resistance. There are other settings, I'm thinking about Gaza probably, where the conflict itself destroyed the majority or completely the health structure and the microbiology laboratories in the war zone. So we have no data at all. I think we should also, it should be discussed the possibility to establish mini laboratory or small microbiology laboratory in military facilities or in military hospitals, in order to at least provide data on the phenomenon and to organize the best response possible.
Thank you very much, Guido. I will then pass back to you, Souha.
Thank you very much, Guido, for a very enlightening presentation. I think we'll take, I'm really very happy to see that we have already 500 people connected, and we have a lot of questions, and we'll try to take a couple more while Rana is connecting. One question from Tahsin is on, there are data on the effect of war chemicals on the resistance in environmental organisms, especially Acinetobacter. You know, there are a few studies published on the effect of heavy metals on emerging resistance in Acinetobacter. I'm just wondering if you have any thoughts on this in particular.
Well, Professor, no. I know recently some data have been published on the issue. It's extremely interesting and relevant, I agree. But we also have news from the war zones that are alarming, that are dreadful, but sometimes it's also difficult to check the reality and the data we are facing. Yes, of course, bombing and the pollution also related to an ongoing conflicts can and probably is interfering with the development of antibiotic resistance, but I don't have sound evidence and on the issue. I think more study are needed. I can remember that since a few decades ago, we started to speak about Asia syndrome and immune-related diseases due to compounds and pollution and external body, also during wartime. I think something similar can go on with antimicrobial resistance, but I think more research is needed to solve these questions, to answer.
Thank you very much. And Dr. Granata, please stay with us because we'll have many more questions coming after Dr. Hajjeh's presentation. It's now really my distinct pleasure to introduce my colleague and friend, Dr. Rana Hajjeh. Rana is a graduate of the American University of Beirut, and she is a public health leader with over 30 years of experience in global health, infectious disease epidemiology, health policy, and diplomacy, among many others. And she currently just assumed, actually, the position of president of Population Council in New York in the USA. This is a premier international NGO that really focuses on population research, addressing issues related to improving reproductive health, particularly in low middle income countries, and empowering women and girls, improving access to health services and education. But before her position in this most recent position, Dr. Hajjeh held various senior positions at the WHO Eastern Mediterranean region. And between 2016 and 19, she held the position of director of the Department of Communicable Diseases Prevention and Control. And prior to joining WHO, she worked at CDC for 23 years, really many leadership positions at CDC, and a lot of important initiatives, including the Gavi HIP initiative, introducing the HIP vaccination to many countries in Africa. And I don't want to spend more time on talking about how many awards and she has received, but Rana is going to talk to us because we want to really listen to her and not spend more time talking about her. And she's going to talk to us about AMR in low resource setting in the Middle East, North Africa region, where she really spent many years working on that. Dr. Hajjeh, the microphone is yours.
Thank you very much again to you and Robert for the invitation. It's my pleasure to really speak on this important topic. As my colleague Dr. Granata said, it's a topic that is very timely in the middle of what's going on around the world these days. And as you see, Souha, I mean, I titled it a little bit different. I titled it AMR and WAR. I mean, it looks like they almost look like mirror images, and whether this is a losing battle or not, because this is, and maybe we can answer some of this during the presentation. What I would like to go through today is just to give you an idea about the immensity of the problem. Of course, everybody is watching the news. I don't think to give a lot of details, but also to give additional data to what Dr. Granata has provided already about how bad of a problem this has become right now. And as a disclaimer, since I'm speaking on behalf of WHO and all my colleagues and the team that worked at WHO. I'm not at WHO anymore, but I just want to acknowledge all the work, and this was part of the work, what I've done during my years at WHO. Region, which covers 22 countries, mostly in the Middle East and North Africa, but also includes Afghanistan, Pakistan, and Iran. It's a region where there's a lot happening these days, definitely never a boring moment, but it's a region that has unfortunately been hit by many emergencies. And I would like to highlight that emergencies in general, whether they are wars and conflicts, which is what mainly is happening in the region, but also during natural disasters, another thing we have to worry about, there is major disruption in health systems, and that's what leads to many of the problems that we are seeing in healthcare setting, including the rise of antimicrobial resistance. So there's been in the region, there's been multiple conflicts, as mentioned already, in Syria, in Afghanistan, in Lebanon, in Pakistan. We've had floods, we've had major natural disasters, and as you know, over the last year, we've seen significant conflicts in Gaza, in Sudan, and now also recently again in Lebanon. So I think the immensity of these issues lead to significant issues in healthcare settings. As you see here, these are just few examples of the destruction that happens as a result. These are actually from Lebanon, specifically after the explosion that took place 4 years ago and the significant disruption that happened in many neighboring hospitals, including, of course, many of the laboratories who serve these hospitals. So overall, these conflicts and these humanitarian disasters have significantly affected the AMR responses in the countries in the region. Numbers by themselves, I know we have been a bit desensitized to numbers, but this gives you an idea about how difficult things are. About 56 million people in the region require now humanitarian assistance. This is almost about 8% of the total population of the region, which is about 700 million, a little bit over 700 millions. In terms of refugees and displacements, we have in the region the largest number of refugees and internally displaced people. So 40% of refugees in the whole world actually are from our region, even though the region itself has only 10% of the global population. Sudan by itself right now has 10.7 million people internally displaced. So this is the largest number of any internally displaced people anywhere in the world. And of course, a very large proportion of all the patients. I will talk about the data coming out of Gaza among patients who were evacuated, showing the evidence of multi-drug resistance. Excuse me. So, these fragile, we call them FCVs because these are fragile, conflict, and vulnerable settings. The initial request was for me to speak about AMR, both in conflict-affected countries as well as among refugees and migrants, because this is becoming a problem not only in the countries that are directly affected, but of course in all the countries where the migrants and the refugees go, and in all the countries where we have injured people being evacuated. And these countries have borne a very disproportionate burden of antimicrobial region. Even in our region, I think, I'm sorry, my connection wasn't great initially. I don't think if Dr. Granata mentioned it, but the war in Iraq led to the significant rise of Acinetobacter baumannii being multi-drug resistant to the point that actually it got its own name. It's Iraqi bacter, and it was not discovered in Iraq initially. It was discovered when the US soldiers went back and other soldiers went to the UK and other countries, and they found that they had wounds that were infected with these bacteria. So to show you some of the drivers of antimicrobial resistance in conflict, I think many of them make sense, but it's important to highlight them. So of course, the destruction of hospitals per se is a huge factor in the rise of resistance. One very important thing is basically the destruction of the WASH infrastructure. Basically, infection prevention and control capacity becomes really limited during war and conflicts, and the priority shifts to many other things. The priority shifts to saving lives. The priority is not about cautious use of antibiotics. Actually, doctors throw all the antibiotics they have usually in order to save lives of people who have been severely injured. Their labs get destroyed often, and even when they are not destroyed, of course, microbiology labs, they shift their workforce to support other labs because it doesn't become a priority to do cultures unless it's really very urgent. There's a significant disruption in supplies. Supplies in general, as we have seen in many countries in our region, that you have no supplies for either basic infection control, WASH supplies. Even in some of our countries in the region that are affected by the conflict, we have sanctions that have significantly limited availability of many medications, many other supplies, sometimes tools and instruments that are necessary for lab work. Of course, vaccination programs, but health routine and well-being health service delivery is quite disrupted. And I heard at the end, I think Souha was asking about the heavy metals. This has been very interesting observations, and there's been some studies. I think microbiologists are better capable to speak about the mechanisms of the heavy metals from weapons and the significant pollution, actually heavy metal pollution that happens in the environment. And there's been some studies already published about the mechanisms and how the bacteria actually develop like efflux pump type mechanisms in order to protect themselves from the heavy metals that end up being present in quite high levels in the environment in these settings. And of course, as was mentioned earlier, during the conflict, routine surveillance systems get disrupted. So the data on exact burden of AMR and really any systematic collection of data gets significantly disrupted. Usually the data focuses on collecting information that is important to manage the emergencies rather than routine health systems. And one as I mentioned earlier, in these really difficult situations, as you see some of the really bad infection control infrastructures, but antibiotics start becoming used as substitute for missing infrastructure, lack of proper hygiene, poor care, and they're one of the tools doctors like to use, hoping that they can save any life possible. Of course, if I step back a little bit for our region, we have had issues with antimicrobial resistance regardless of the conflict, or maybe the chronic conflict had contributed to it over the years. It's hard to tell. But from the gram data, I mean, we know that our region, as you see on the left, in the left graph with the blue line, our region has had the highest rates of antibiotics consumption compared to other WHO regions. When we talk about our region, we are referring to WHO. And we have seen, again, from the GLASS data, we have seen significant increase both in rates of the Enterobacteriaceae, such as E. coli, ESBL, and MRSAs. And although, interestingly, also from our previous data, we know that low-income countries tend to have relatively lower antibiotic consumption, which we assume may lead to less resistance. And part of the reason for that is usually lack of access sometimes to these antibiotics in basic healthcare settings. I thought before we get into the what is available in terms of data from the region for countries in current conflict, I thought it's good to share this article that was published from Syria, and actually presenting some drivers from before the conflict, not only during the conflict. So the pre-conflict conditions had also facilitated rise of resistance in many of these countries, including factors that I'm sure the participants are quite familiar with: the availability of antibiotics without prescriptions, overuse and prescription of antibiotics, lack of any significant stewardship programs, poor IPC, bad nosocomial surveillance, which basically you don't have a good assessment of the problem in order to prevent it, and poor capacity for human resources when it comes to strong microbiologic capacity and infectious disease specialists. And as I mentioned, during the conflict, many of these factors are exacerbated or added, including, in particular, the destruction, death of healthcare workers. We are losing a significant number of our healthcare workers in the region, whether they are physicians, nurses, lab professionals during the conflict. Many of them either pass away, unfortunately, during the wars, or they leave the country to protect themselves and their family. And of course, the overcrowding and displacement makes the spread of these organisms in the communities also very accelerated. As you see, many of the consequences, the inability to really do good data collection or perform surveillance is one of the immediate consequences. Also, we've seen sometimes because of the lack of supplies or the limited supplies, we've seen fake antibiotics being used in many of these settings. I'm gonna try to show, again, I apologize if Dr. Granata, I wasn't following. I'm sorry, because I was on the road, but I don't think these studies in particular were shared. These are three different studies. The references are mentioned at the bottom of the slide. The first one on the left actually is from Gaza hospital. This was older data before the current conflict, what was the previous conflict back in 2018, 2019, that is referred to as the Great March of Return. And this is from non-injured patients. This is the data that was collected before and after the conflict. And you see the significant increase in many of the antibiotics, whether they are, doxy or some of the aminoglycosides, as you see here. The study in the middle was in Mosul, Iraq. It was in post-war Iraq, and as you know, Iraq had conflict almost for 20 years. We don't have pre-war data, but this study is showing that the total prevalence of multi-drug resistant various organisms, as you see below, MRSA, other various ESBL, Enterobacteriaceae, and other is over 70%. I mean, this is really alarming prevalence. And the third study was from hospital from Adan. It's an acute trauma hospital in southern Yemen for 3 years between 18 and 21, also showing the very high level of resistance, ESBL in Enterobacteriaceae and other organisms. This data is from GLASS, and the data I'm just listing it really for the completion of presenting all the data I could find, because it's variable. This includes a variety of countries, but this is probably the largest database we have from countries in the region. And if you are interested, again, the references are many of them are listed in this review, very nice review article by Tropa and Abu Shahada in BMC, because it lists all the study. This is probably the most complete on GLASS data, in particular looking at various countries in the region, whether conflict or non-conflict affected, and the rates vary, but they're still quite consistent, as you see. For example, the in conflict countries for Acinetobacter, it's 78% versus only 72% in non-conflict countries. So it's still quite consistent with the studies that were previously presented. This is the last one. I don't know, Souha, maybe I hope I still have a few more minutes.
Yeah,
but this
maybe
is the
two more.
last
Maybe
study
2 more
actually
minutes.
that was
2 more
just
minutes,
published
Rana.
as in just last year, and this is from one of the hospitals that is supported by Médecins Sans Frontières, Al Auda Hospital. It's it's a reconstructive surgery project, where they found that before the current conflict, they had 70% of their cultures were all multi-drug resistant, mainly in patients with osteomyelitis. 65% of the Staph aureus were MRSA, and 35% of Pseudomonas isolates were resistant to ceftazidime and the carbapenems. A significant proportion of ESBL in the gram-negative isolates. From the current conflict in October 7 and as of November 1st, they were just giving, they didn't have data collected systematically, but they wanted to show the burden. So basically, with only 2,500 bed, in like 3 weeks period, they treated 20,000 wounds. And 1/3 of the other hospitals in Gaza were not functioning because of the fuel shortage, as well as the direct attacks. So that can tell you the significant burden and why it's so difficult to ensure good antibiotic stewardship. Sorry, can you hear me? Sorry.
Yes,
Souha?
Rana, can because we need to keep some time for questions, if you can conclude in like 1 or 2 minutes, please.
Cool.
Yeah.
Well, okay, sure. I'm gonna go over. I had some data on the refugees, but I will go through it quickly. Maybe can I do like 5 minutes max? Or let me do. I'm gonna go quickly because I had some data on antibiotic use. For example, in Sudan, if you see that 20% of all antimicrobials prescribed in healthcare settings were actually third-generation cephalosporin, just showing the excess use of the broad-spectrum antibiotics. I just had few slides, Souha, about the refugees, and again, these are populations that also by themselves present significant risk for many countries in Europe, like the Netherlands and Germany, reporting increasing number of MDR Enterobacteriaceae in there, especially with some of the refugees coming from Ukraine. Again, multiple factors affecting the spread of AMR among refugee hosting settings, the crowding, the poor hygiene situations, of course, and a lot of the data that is coming to us actually from is from Europe, where you see, for example, that in Denmark, they were highest rate, as you see in the red circle of MRSA, was from patients coming from the Middle East and North Africa.
Rana,
I wanted to highlight that
Rana,
WHO did.
Rana, I'm so sorry to stop you here, but we really, because we only have 1 hour for this webinar and we have 5 more minutes. So I think I prefer to stop here and take
this is the last slide.
Okay.
Let me just, this is actually my last slide. I just didn't want to end on such a gloomy note, because it's really, the situation is very dire, but I think there are things we can do to try to win maybe part of the fight against AMR during war and conflict. I think the importance of really advocating for the importance of these settings having very basic needs for IPC covered, very basic medical supplies, and really to make sure we have a humanitarian corridor. This has been a huge struggle to be able to even transfer wounded patients and supporting them to neighboring countries, and to make sure that any emergency preparedness plan incorporate our prevention packages. But last but not least, I really want to have a plea that we should all advocate that hospitals should not be targeted, and hospitals should be a red line, and they should be protected both for the sake of patients overall and to protect healthcare workers. So thank you very much for your attention, and to highlight that this is a very important year for AMR with the recent UNGA declaration, with a big meeting coming up on AMR in Saudi Arabia in November. I sure hope that we can make progress on this important topic. Thank you, Souha.
Thank you very much, Rana, for this overview. I think you really raised so many alarming points regarding the issue of AMR in the Middle East North Africa region. And I think between what you presented and what Guido presented, we really have a good overall idea of how the magnitude of this problem really. We have a lot of questions, and I'm happy that Fee, we'd like here to thank Fee Johnson, who is working with ISAC, and she's really the drive behind making sure all the logistics for this webinars are happening on time. She's texting me to say we have 15 minutes. So the webinar is for 75 minutes and not 60 minutes. So we have plenty of time to address a lot of the questions that have been asked. So I'm going to take a couple of questions and then pass it on to Robert to take additional questions. There are a lot of comments and really interesting questions that are being asked. I'm going to start with one addressed to Dr. Hajjeh. One question about, from the data that, little data I would say, that we have on AMR and war-injured patients or in refugees, etc. They're questioning if we have any surveillance data from admission to the hospital prior to them being in the hospital, so that we get a feel of how much is it acquired from the community versus nosocomial infections with these multi-drug resistant pathogens.
Yeah, thanks, Souha. There is some data. I think, it's actually both. But, basically in settings like chronic conflicts with patients with wounds that do not heal completely, they are in and out of the hospital. It's very difficult sometimes to identify where the initial source of infection is. So these, with patients going back to the communities, because hospitals also cannot keep patients until they are fully healed. So patients are going back to the communities with these multi-drug resistant organisms, and the organisms are spreading in the community. So I think we know for sure that there is significant healthcare associated transmission, but also I haven't seen very good studies focusing only on the communities, because most of the data we have is coming from the hospitals. But actually many of them have reported that many patients are recurrent admissions, and they're bringing these infections back with them into the community.
Thank you, Rana. So question to Dr. Granata, are you aware of any studies addressing colonization of displaced populations from the Ukraine war? Any available data on the level of colonization?
Yes, Professor, I'm not sure I get the question. Colonization?
Yeah, so
In general terms.
colonization among the displaced populations that
Yes.
left Ukraine to go to some of the European countries. Do we have any data on colonization with multi-drug resistant pathogens?
Yes, there are available data, especially regarding, or at least in my experience, especially regarding from combat zone to other countries. And again, they highlight that the rate of MDR colonization is high, alarmingly high. And there is also one study quite interesting because it is one of the few studies reporting a correlation between increase in MDR colonization and death during a subsequent infection in the hospital. By the way, to reply to the answer, yes, there are data on higher colonization rates among refugees.
Yeah, thank you, Guido. Robert, I pass the microphone to you.
Well, thank you very much, and I also want to congratulate Rana, your very nice presentations. I actually have a question for both of you, taking from the chat here, because one thing you did not, as far as I heard, mention, is there a problem with substandard or falsified, or an increased problem with substandard or falsified antibiotics in your experience, or from what you have seen in these war zones and where medications can be very difficult to obtain? So I don't know, Rana, do you want to start?
Yeah, I'm sorry. Yes, sorry. Thank you, Robert. Let's see here. Yeah, I mentioned briefly, I think, as one of the factors that the fake. We know that in many of these countries, because of various factors, limited supply. In some countries we have sanctions. In some countries we have just countries have not been able to bring these medicines, all the essential medicines, enough quantities that there's been enough fake antibiotics and fake medicines overall. But to really, it will be very hard to basically estimate what proportion of the resistance is due to the use of these. But we know that this is a common problem, and we have seen it in particular in these conflict and in refugee, some of the refugee camps and other similar vulnerable settings.
Guido, do you have anything to add here?
I only want to add that, again, it is difficult to give you an answer because of the extreme heterogeneity and variety of available study, and also of, I think, different protocols and procedures regarding the antibiotic administration adopted by different military organization and also different countries. Reviewing the literature, I have found a huge variety of different antimicrobial compounds and guidelines, kind of military guidelines to treat wound soldiers on the battleground or immediately after the transfer to the field hospital. There are also studies, for example, that were conducted to understand if an immediate dose of broad-spectrum antibiotic at the time of the injury or of the gunshot could be useful. The answer was no, it is not. But again, I think we need more study with more sound data, preliminary data, in order to answer to these questions.
So a follow-up question, I noted that you, Rana, presented some data where you looked at pre and post, but has there been more examples of this where you actually have looked at pre, during, and what happened afterwards? In other words, did the resistance level, the higher levels that you showed during, do they continue in a country post-conflict, post-war? Do any of you have any data on this? Rana, will you start?
Yeah, well, you know, actually, maybe if anyone would have data, it will be Souha probably, because, you know, unfortunately, you know, Robert, many of these countries are still in conflict. The problem we have is many of these countries are in chronic conflict situation. We have countries like Lebanon that has been in and out of conflict, right? But you know, Iraq went through 20 years of conflict. They are just starting to emerge from it. So it's going to take consistent surveillance over multiple years to be able to monitor the data. I think AUB, if I remember, I've seen data from various studies in AUB because they've had and other hospitals in Lebanon having looked at rates of resistance overall. But again. You know, knowing the current conflict situations in these countries, especially in the region where, you know, there's always some kind of even low-grade conflict going on. So it will be very hard to separate, you know, what proportion, for example, of wound infection. You need a study that looks very systematically at, for example, wound infections, whether they are coming that are conflict-related versus other types of wound. So I don't know, maybe Souha can address that from the hospitals.
Yeah, I think so. Tony Abu Fayyad and Ghassan Matar in our university, they're very interested in looking at this problem of AMR among wounds, and they've accumulated a very large number of samples from the wars in various countries in the Middle East. But and they're in the process of analyzing that. But I can tell you for sure that often we do see patients admitted to the hospital, and within 1-2 days, they are infected with multi-drug resistant Acinetobacters and Carbapenem resistant Enterobacterialis. We also are seeing resistant fungal infections, including Aspergillus species, among patients injured during the current war. And these are infections that are diagnosed upon admission to the hospital. Now, obviously, the longer the patients are in the hospital, the more likely they will later develop more and more resistant pathogens. But even on the day of admission, these patients seem to get infected with multi-drug resistant pathogens. But we will learn more about the microbiology of wounds from the Middle East, North Africa region once the study is completed.
Yeah, and maybe also just, Robert, to emphasize again that spillover effect that's happening, because during conflict, you know, hospitals cannot keep patients for too long. They need the beds. So these patients are sent back home with really open wounds very often to be taken care of at home. And I think the danger of these multi-drug resistant organism being really taking hold in communities is also very, very concerning, and also spills over to other countries, because these, you know, people are traveling, they're going to other countries, they're migrating. So I think it's not, I guess the point I want to make, this is not only a problem in conflict countries, this is going to be a global problem if we don't take serious measures to control and to prevent as much as possible the rise of such infections.
So Guido, sorry, Souha.
No, go ahead, Robert. I was just going to ask Guido about the alarming rates of resistance in Ukraine, even to the very novel antibiotics. And I was wondering if there's much use of these novel antibiotics in Ukraine, and therefore the high resistance, or these are developing even though the drugs are not available in Ukraine, the ceftazidime avibactam, the ceftolozane tazobactam, and other novel drugs you mentioned.
Reading the published article, it seems that this kind of antibiotics have been used in at least a percentage of injured soldiers at a certain time during the hospital admission after the war wounds. Yes, I also want to say I completely agree with what you have just said. Reading, in my experience, the phenomenon of antimicrobial resistance during war can start in the military hospital and then in the hospital, but then inexorably, after, depending on the duration of the conflict, it dilutes on the community, and the effect of this antimicrobial resistance can stay and persist for years in zones and in countries that face the unarmed conflicts. And we have data also regarding gram-negative multi-drug resistant bacteria, but also MRSA and gram-positive bacteria.
Yeah, Robert, pass it to you.
Yeah, I see that we are getting quite close to the end of this one here, so I think we may have time for just one last question here. Unless, Souha, is there anything you would like to emphasize before we close? Oh, you're muted, Souha.
I'm getting from Fee that we can extend few more minutes if you have time. I'll leave it up to the speakers and to you, Robert, if you'd like to take additional questions, because there are many still that have not been answered, and I see the level of interest is there, but I leave it up to you, Robert.
Yeah, well, I think in fairness to all people, I think we can take just a few minutes more, and then. But I'm so happy to see that we are still having almost 400 people present at this time here. So it really shows, and also when I look through the comments, that there is really very many comments, not only questions on the importance of this topic here. So one question, or no, well, it's actually a bit of a comment where it is mentioned there that there is mobile labs by MSF that has been recently introduced. So I believe I've heard that there is at least one in function in the MENA region, but Rana, can you confirm, and can you tell a bit about is these labs well functioning?
What I know, Robert, is that it has very limited capacity to function because of the security issues. It's really not safe for them to move around. In Gaza, they wanted to have a mobile lab so that they can support more than one hospital, but its capacity to do that is very limited. It's not a priority. It's really not a priority in these conditions. We were trying to actually collect some data from neighboring hospitals, for example, in Egypt across the border, because many patients, Egypt received the largest number, and really they have to be acknowledged for the level of support they provided. They tried to get data on patients who were injured right now, but even for MSF, they're finding it very difficult to conduct the microbiologic surveillance they really need to do in these settings. I don't have updated information on whether the mobile lab, but I know from my earlier communication that they had very limited mobility.
I just can add to that. They did have a small operation in Gaza because the team in the MSF team in Lebanon is also communicating all the time with the team in Gaza, and they were trying to establish some activities around antimicrobial stewardship collecting some data prior to the October war. I think currently they're no longer functioning in Gaza, but their office in Lebanon is still functioning, and they're trying their best to really complete their mission as much as they can, considering all the challenges.
So, Souha, one last question from your side.
Yes, so there was just a question for Guido, I think, about data from Kosovo and Pakistan, because a couple of people mentioned if you're aware of any antimicrobial resistance in these two countries that have had their shares of wars.
Well, Professor, no. Regarding Pakistan, I'm not aware of solid, consistent data on antimicrobial resistance, but I have to say I mostly focused on incidence of antimicrobial resistance. Probably we have data regarding the incidence of bacterial infection in this country, but I could not find reliable data on assessing the incidence or the causes of antimicrobial resistance in Pakistan. And for Kosovo, I know there are some published articles in the literature. There are a few studies performed on both sides of the conflicts, but in my mind, I can remember they are quite preliminary data. Again,
Right.
focusing on the higher incidence of infection instead of the antimicrobial development.
All right. I think with
So,
that, I'm going to pass it on. Yeah,
sorry. Just wanted to add that Pakistan is one of our countries, and they actually do contribute to GLASS data significantly. The NIH in Pakistan is one of the it's a big country, and they actually provide quite a few isolates. And there are few studies in the literature. I did not highlight them because there's no really active conflict in Pakistan, but there are few studies published, and they do have very high rates of resistance. Again, antibiotic use is rampant there without prescriptions, and the infection control is really poor. So it's a bad combination.
Yeah, with that, I think, well, first I'd like to I'm going to pass it on to Robert to conclude, but I just want to thank the speakers from my side, but also I wanted to tell the attendees that this was a recorded webinar, and it will be made available on both the ESCMID and the ISAC website. And clearly, this is a topic of interest to a lot of people, and we're going to only see more and more antimicrobial resistance with the ongoing wars in many parts of the world. I'd like to thank you, and I'm going to pass it on to Robert to conclude this webinar.
Thank you very much, Souha. And first of all, I really would like to thank both speakers, both Dr. Guido Granata and Dr. Rana Hajjeh, for these excellent presentations. I obviously also would like to thank my co-moderator, Professor Souha Kanj, for this to be joining us in ESCMID. So we have this first ISAC ESCMID webinar. Given the interest of this one here, I'm certain that we will follow up on this. I see it has been really fantastic to read all the comments and questions in the chat. I'm sorry we couldn't reach to answer all of them, but there has been really fantastic comments. So at least I will urge you to relook, just to look at some of the comments here. And I would like to end a bit with what the last slide that Rana Hajjeh was showing, that we really need to get the basics right here. We need to do the things that are a possibility in in these very, very distressful situations. As one of the attendances wrote, it's more important to survive than to think of AMR and this. Well, as another one wrote, we actually see, they see in Ukraine now that this year is not limited to hospitals who is treating war injuries, but it's actually all over Ukraine at the moment. And even we in Denmark, when we are receiving refugees from Ukraine, they don't even have to be at a hospital, but they come with colonized with multi-resistant bacteria. So it is indeed a very, very problematic situation that we are facing in this one here. So once again, on behalf of ESCMID and the International Society of Antimicrobial Chemotherapy, thank you to all of you for your active participation. And we want to say thank you for being here together with us today. And I cannot give a big hand, but I really would like to give a big hand to all of you for the fantastic presentations. Thank you.
Thank you all. Thank you. All the best. Bye-bye.
Thank you.
Thank you.